So 3, 2, 1. We are live now. Over to you, ma'am.
Dr. Aarti, shall we only take it forward because we have to go through the list of the participants then, because I'm here, I have to open my mail otherwise. Dr. Roshni, do you have the list of the participants with you?
No, actually, even I don't have the list of participants.
Okay, so I think from your side, you can only take the list and start giving the space to the participants so that they can themselves come one after the other. And may I know the time limit given to each participant?
3 minutes. That is 3 minutes.
3 minutes to present the paper.
Present and then
time to interact.
Interaction, maybe 3 minutes we can.
Okay, so totally in 5 to 6 minutes we need to finish
Okay.
it. Maybe 6-7 minutes. Okay. So who is the first person to present? Dr. Minnu.
The first presenter, Dr. Minnu Thomas. Are you here?
Can you unmute yourself, Dr. Minnu?
And the registration numbers there on
84.
the corner. Okay, 84. Okay.
Yeah. Okay. I'll present, ma'am.
Yeah, you can start off.
Good morning, everyone. Good morning, judges. Today, I'll be presenting a case review about a child who got admitted with fever as her only complaint. A 12-year-old girl got admitted with complaints of high-grade fever, which was continuous type with chills and rigor, and generalized tiredness of 3 days duration. On examination, she was found to be febrile. That is, her temperature was 102.2 Fahrenheit. Her vitals were stable. On examination, there was a left upper cervical lymph node palpable, which was 2 centimeters, firm and non-tender. All of the systems examination were within normal limits. On the day 3 of fever, that is on the day of admission, the investigation sent TrueNat for COVID-19 came out to be negative. Her total counts were 3,800 with a neutrophil lymphocyte ratio of 76:16, which is more than 3. And her platelet count was 1.4, ESR 46, and CRP 123. She was started on IV antibiotics, that is IV augmentin, 5 CRP. On the 5th day, the findings were she developed loose stools with persisting fever spikes. So IV antibiotics got changed to ceftriaxone and IV amikacin. Dengue NS1, IgM, lepto IgM, and the malarial parasite percent, which all came out to be negative. CRP was persistently high with leukopenia and thrombocytopenia. On the 6th day of fever, child started developing abdominal pain and distension, and there was pain and swelling of the ankle, knee, and elbow joints. Fever and loose stools were still persisting. On examination, the child was sick-looking with a temperature of 104 degree Fahrenheit. There was joint swelling and tenderness in the elbow and knee joints. There was periorbital edema. On examining the abdomen, it was diffusely tender with distension, and chest showed bilateral crepitations. Her BP was maintained at 100/70 with a saturation maintained at 98%. Ultrasound of the abdomen was done, which showed enlarged para-aortic lymph nodes with multiple mesenteric lymph nodes with colitis and splenomegaly. MAN2 test, wide ANA immunofluorescence, RA factor, ASO titer, Paul bundle test, all tests came out negative. An echo was done, which showed myocarditis with enlarged pulmonary artery, mild MR and TR. In view of multisystem involvement, inflammatory markers were sent. So D-dimer came out to be 4,322, serum ferritin was 1,778, LDH was 452, CRP was 177, and COVID antibody was also sent, which came out positive. So in view of this multi-system involvement and the lab investigations in favor of MISC, the COVID antibody positivity altogether confirmed the diagnosis of MISC. Retrospective history was taken, which confirmed contact with a positive case. IVIG infusions were started and pulse dose of methyl prednisolone, which resulted in improvement of the GC, and child was better and fever subsided. The differentials will be systemic onset JIA, abdominal TB, systemic vasculitis or connective tissue disease, and COVID MISC. The final diagnosis is post-COVID-19 multisystem inflammatory syndrome in children with myocarditis with mild MR and TR. And as a conclusion, I would like to say that as a family physician, every child we evaluate with high-grade fever and an NLR ratio more than 3 with a history of just a COVID contact should be evaluated, keeping in mind the possibility of MISC, that is multi-system inflammatory syndrome in children. Thank you.
Thank you, Dr. Minu. I'm surprised whether you didn't ask a COVID contact history in the beginning. Why was it retrospectively asked?
That was because, ma'am, initially TrueNat test was done, which came out to be negative. So we knew it. There was no that is, the patient was not COVID positive. So we were only evaluating that, ma'am. That is only when the everything came out to be negative did the diagnosis of a post-COVID MIS came into our minds, and then only we asked for a history of a contact. The contact history was there, but it was still, the patient was not positive, no, ma'am. So we were not having the diagnosis of MISC in mind initially. We were evaluating for dengue and all that in the beginning. So it was only towards a later phase when everything came out negative that we knew that MISC came out with a post-COVID case also.
And also, before starting an antibiotic, do you normally do a blood culture? Because I was looking at blood culture here. You have
Yeah, ma'am. Blood culture was done, but it didn't give out any growth, ma'am. We usually sent blood cultures, ma'am. Yes.
in the initial stages.
We started the antibiotic in view of high CRP, ma'am.
Mm-hmm. So currently in this, you have not mentioned about blood culture, but was it done? I didn't find.
Yes, ma'am. Yes, ma'am. Before starting the antibiotics, we sent a culture, ma'am.
Okay. So how possible is that, the COVID antibody could have been even a previous infection? Did the child have any previous COVID antibodies are usually there for approximately 3 to 6 months. So is it a possibility that it's a late onset immune response to a previous COVID infection versus a current infection?
Sorry, ma'am. What you meant was whether this was a current infection or a post-COVID inflammatory response.
Inflammatory response.
Ma'am, her COVID was a month back, ma'am. So most likely chance would be a post-COVID inflammatory response.
Okay, so you mean to say the child would have had an active COVID infection a month back and now this?
Yeah, an asymptomatic one, ma'am.
Okay, so this is a post-COVID inflammatory response is your current diagnosis.
Yes, ma'am.
Roshni, anything?
Dr. Minu,
Yes.
it is a very relevant case as far as the present situation is concerned. You have done it well. Okay. So, were there any other similar cases among the contacts?
Among the contacts?
Among the contacts of this child?
No, ma'am.
No,
among everyone in her house, like with the contacts, only she developed the inflammatory response, ma'am. Others were just asymptomatic. Nobody tested positive for COVID, ma'am. Even she was not positive for COVID. So it's only when the inflammatory response came, we got a history of contact. So we are assuming that she might be, with the COVID antibody being positive, she definitely might have gotten asymptomatic.
Okay. Did you come across any other similar cases during the past 3 to 4 months?
Yes, ma'am. There was in the pediatric ward itself, there was another child, a 1.5-year-old baby, who was he was diagnosed as a case of MISC. He was brought unresponsive, ma'am, with just 1 day history, and on evaluation, similar investigations were done, and finally we got a COVID antibody positivity with lab investigations, all inflammatory markers in the COVID range, ma'am. So from that, with steroids, the baby improved, ma'am, and IVIG.
Okay, thank you, Dr. Minu. Dr. Sapna?
Will you be continuing the steroids or you're going to stop with the pulse steroids?
No, ma'am. Both of them were sent home with steroids, ma'am, and they were tapered with OP visits, ma'am.
Okay, so you have a final follow-up also where the child is really doing well?
Ma'am, until in the hospital, I've got a follow-up, but once she's gone home, I'm not able to contact her, ma'am. She's not picking up. So only up to the hospital thing I have. She was referred to a government setup because of financial burden. She couldn't afford the IVIG here or the ICU treatment. So she was sent to Anthropometric College. From there, I followed up, but after going home, I've not got a proper follow-up.
One more concern is about the MAN2 in this age group. How relevant is the MAN2 in this age group? It's a 12-year-old child. So
It's a 12-year-old child.
Keep that in mind. probably a blood culture, and probably giving a history in the previous, because in this scenario, taking a history of COVID contact later on kind of gives us a little skepticism as to why this didn't come up in the first instance. So there probably I would have done a repeat RT-PCR, 3 days
Okay.
later, instead of probably waiting for an antibody. I do agree that, but with one RT-PCR negative, treating the patient and then doing an antibody, maybe another RT-PCR. If I had got the history, that's my thoughts.
Okay, ma'am.
Very good, very relevant case.
Okay.
And I loved your the presentation as a misconception about.
Thank you so
Did
much.
you mean a
Okay, the way you have
misconception
done it,
about
it's
COVID?
beautiful.
Yeah, that is also very nice.
Okay. Thank you so much.
Dr. Minu. I'm sorry for the delay, Dr. Sapna and Dr. Roshni. We'll go for the next talk, Dr. Navina Prince Chandy. Arati?
Good morning, ma'am.
Yes. Please let
Good
them share the
morning.
slide. Just a minute.
Yes, ma'am.
Ma'am, am I audible, ma'am?
Yes, you are audible.
Yes. Dr. Navina, 43, right?
Yes, ma'am.
Okay.
Arati? Yes. Yes. You can start, Navina.
Good morning, respected judges and my dear friends. Today I'm presenting the topic, a cross-sectional study of persisting symptoms following 2 months post-COVID-19 and risk factors for delayed return to pre-COVID health among patients attending tertiary care hospital in Kerala. So the background of my study is a large number of people are being discharged from the hospital following COVID-19 without assessment of their recovery. So systemic follow-up of these patients after hospitalization with COVID-19 helps us to find out the physical and physiological burden, which could be used to inform the need for rehabilitation and further investigations. So aims of my study was that to study about the persisting symptoms 2 months post-COVID-19 and to determine the risk factors that cause the delayed return to pre-COVID health among patients attending a tertiary care hospital. The methodology of my study was a cross-sectional study was done. The sample size of 100 who were tested positive by TrueNat in the month of August to September. They were collected from the medical records and phone call interviews were done, ma'am, 2 months post-COVID-19. And they were asked for the persisting symptoms at that point and risk factors were noted. Data was analyzed using various statistical methods. The results and conclusion of my study was that out of the total population of people who contracted COVID-19, 71% of patients were males and only 28% were females. And only 34% could recollect any history of contact with COVID-19. And the most common symptoms were a fever, cough, sore throat, loss of smell, etc. And most common comorbidities found were diabetes mellitus and hypertension. Among 103 cases taken for the study, about 44% of the patients took treatment from home and 55% took treatment at the hospital setup. And my study also reveals that, ma'am, cases with post-COVID symptoms are significantly higher in cases who took treatment from hospital compared to cases who took treatment from home, which implies that patients with severe disease had post-COVID symptoms more than category A patients who are usually advised home treatment. My study also highlights that persisting breathing difficulty are significantly higher in cases who had pre-COVID asthma or COPD compared to cases who had no pre-COVID asthma or COPD, which makes COPD and asthma patients to be considered high risk for post-COVID sequelae. Realizing the fact that persisting dyspnea and cough were significantly higher in cases with dyspnea and cough as a presenting symptom compared to cases who had no cough and dyspnea makes treating people who present with breathing difficulty and cough very important to curb the morbidity associated with persisting dyspnea. To conclude, I would like to say that as a family physician, a family physician's role is very important in the follow-up of COVID-19 patients, and clear understanding of the post-COVID sequelae is very important and essential for that. In the near future, I think we'll be having more patients who are coming to our OPD with post-COVID symptoms, and systemic analysis and follow-up of these patients are very important to curb the morbidity associated with it now. Thank you.
Okay. Okay, Dr. Navina. That was very well done. That presentation was very well done. So you have found out that the patients who were admitted in the hospital, that is those who are not in the category A, they are the ones with more symptoms, right?
Yes. Yes,
And
ma'am.
also the previous history of asthma and COPD, they are also a risk factor for aggravation. So after the study, what can you do for the patients? Like you have found out some data. So now what will you be able to do for the patients following the study?
Ma'am, as a family physician, I think we have to systematically follow up these patients, maybe monthly or according to their requirement. And we need to assess them properly for this post-COVID sequelae. And we have to think this in mind, otherwise we might miss that part. And assess and treat them the most possible way possible. And I think this also calls for more research into this field, ma'am, because it is a new entity for every one of us. I think we have to do more research on this persisting symptoms post-COVID sequelae, and government should take some rehabilitation measures also for these patients, ma'am. And as a family physician, we are best in position to do it at our OP.
When you are discharging the patients, will you be will you keep a set of advice that you will be able to give them? Maybe you can design a set of advice, like asking them to come back if they are developing any symptoms. Okay.
As of now, ma'am, in our setup in our institution, we have a post-COVID separate follow-up care where we invite them to come every month for spirometry and even chest examination or auscultation.
Okay. So this study can contribute towards that also.
Yes, ma'am. Definitely.
Okay. Dr. Swapna?
Yeah, I really love this concept of your study. You know, it's a very unique concept, I feel. Did you look at the inflammatory markers of the patients during the stay? Whether did that contribute to their recovery? People with high inflammatory markers had was that one of the variables?
No, madam. We didn't have that in my concept. Actually, I have taken a post-COVID survey. We have not gone into the investigation part. After 2 months, we are doing questionnaires over the phone. Questionnaires were done.
Okay.
I have not gone into the investigation part.
Okay. And
just I wanted to see the risk factors.
Which are the variables in the history that you have taken? You mentioned diabetes, you mentioned asthma, COPD. Which were the other, questions in the questionnaire that you had?
In my questionnaire, I actually had questions like age and the risk factors were taken in consideration, demographic variables, their society, where they're living, their home facilities, all those things were taken into consideration. Other than that, nothing, ma'am. Mostly I was concentrating on the post-COVID also to correlate the risk factors. Post-COVID, all the symptoms were taken into consideration, ma'am. Even the anosmia, ageusia, all these questions were asked to the patients. And we found that fatigue was most common, ma'am. Almost 30%, 40% people had fatigue. And comparing to the older studies, we found that all the studies, even in Wuhan, China, everyone showed the same. Fatigue was most common. Even dyspnea, which is very relevant, ma'am. Almost 20% patients had dyspnea.
Did any of your patients end up in a post-COVID sequelae which required admission? Anything like that, or like
many patients had to yes, ma'am. We had to follow up them from the pulmonary side. They were admitted under pulmonary respiratory medicine department, and many of them actually curved to death also. We have excluded them from the study, but many of them even died because of post-COVID sequelae.
The study can really be extrapolated for some more time, because Kerala, there's still a lot of active cases, plus I'm sure in the last few months you will be having a lot of post-COVID patients.
Yes,
so
ma'am.
if you can take up this study and extrapolate it and understand as a family physician which patients you should be calling up more frequently compared to which patients you can leave them.
Yes, ma'am. Those who require rehabilitation.
You are the person who can have post-COVID symptoms later on, so be careful. That will add a lot of value to your study. That's what I feel. Maybe markers could also be an added variable if it permits, because you're already in a tertiary care, so you'll have definitely the markers of the patient. So how much is markers correlating? Did patients with high markers end up in sequelae versus patients who had low markers?
Yes.
So then as a family physician which patient you need to be tracking more often. And which patient you can leave them and say that if you have any problem, you come back to me.
Yes, ma'am.
So that's a very good concept. I just love the concept.
Okay, thank you, Dr. Navina. Can we go to the next talk? Dr.
Thank you, madam.
Nishana. Dr. Nishana. Dr. Nishana, are you there? Yes, unmute yourself.
Good morning, ma'am. I'm presenting from another person's laptop. So name is different.
Yeah, no problem.
Okay.
Start off. Start off.
My topic of presentation is knowledge, attitude, and practices regarding inhaler use in adult patients with chronic obstructive pulmonary disease and asthma. A cross-sectional study conducted in Lourdes Hospital, a tertiary care hospital in Kerala. The study was done under the guidance of Dr. Ham George, HOD in General Medicine, and Ms. Kaimal, HOD in Family Medicine. Background of this study: although this study started in 2019, at that time there was no COVID-19 and all. The background is inhalation devices are a mainstay in the management of chronic obstructive pulmonary disease and asthma. But as the study progressed, then COVID-19 came, and we were facing a lot of restrictions in using aerosol generating practices like nebulizations and all. So then importance of the study is that how efficiently the patients can utilize these inhalation devices. Inhalation devices with proper usage, they are equally effective. Even though even in emergencies, in pediatric emergencies, it is said that inhalation devices are equally effective as nebulization. So we have to explore more. And many of the previous studies shows that even 50% of the patients have no correct practice of inhalers. So this was the background. And analyzing the previous studies and all, there were not much KP studies in this. KP studies aimed at the knowledge, attitude, and practice of inhaler itself. There were many studies regarding the knowledge, attitude about asthma, COPD, and all, but not much assessing the stigma towards the inhalers or correct practice and all. Then aim and objectives: to assess the knowledge, attitude regarding inhalers and its use and benefits in adult patients with chronic airway diseases attending a tertiary care hospital. And the next aim was to assess the extent to which actual inhaler users follow the correct practices. Here in the study, I have included 102 patients. According to a previous study done in Kerala by Vishwanathan and et al., the sample size was calculated as 102 based on this prevalence, and it was a cross-sectional study done from January 2019 to June 2020 among the patients with chronic airway disease attending the outpatient clinics and inpatient wards of Department of General Medicine and Family Medicine. After obtaining informed consent and applying the inclusion and exclusion criteria, this patient was given the questionnaire. A pre-tested validated questionnaire was given. First part contained questions regarding the socio-demographic factors like when the socio-economic status, when was the disease diagnosed, number of hospital admissions, and some questions regarding the knowledge, attitude regarding inhalers, different types of inhalers and all. Then a second part contained questions to assess the practice of current inhaler uses. That I individually assessed the practice of each patient. Then practice, knowledge, attitude, everything was scored. And results and conclusions: among 102 patients, around 50%, that is 47% had excellent knowledge and 50% had excellent attitude. But in 102 patients, only 90 patients were using inhalers, out of which only 77 patients demonstrated the practice of inhalers, in which only 39% have correct practice. It is clear from these graphs. There are about 50%, roughly 50% of the population had good knowledge, attitude, but only 39% have correct practice. Though it is done in 77 patients demonstrated the practice, roughly most of them have incorrect practice. The most common error in practice was no breathing out prior to inhaler use. Around 61% didn't know that before inhalation we have to breathe out. Then breath holding was poor, 29.8. Then fast breathe out, and though minority, a 2% did not inhale the medicine at all. Then the relations knowledge is significantly higher in younger patients. Younger patients up to 50 years compared to older age groups. And in healthcare workers, knowledge of inhaler is more. Knowledge has no relation with gender, education, duration of diagnosis, and number of admissions in hospital in past 1 year. Attitude is significantly higher in healthcare workers compared to others and those with a higher duration. Attitude towards inhaler is somewhat good. Then attitude has no relation with age, gender, education, occupation, and number of hospital admissions in past 1 year. The most significant finding I got in the study is correct practice is significantly higher in cases with no hospital admissions. While assessing the severity of asthma and all, we give importance to the number of hospital admissions, and more than 2 hospital admissions is definitely the disease is not controlled. Here 100% of more than 2 admissions, 100% of that category had no correct practice. That is, none of them has correctly practiced inhaler use. Then correct practice has no relation with age, education, occupation, duration of diagnosis, family support, self-confidence in using inhalers, even knowledge about inhalers, and whether they are trained by a doctor. So the conclusion from the study is primary care physicians have to address the stigma towards inhalers. Here it is evident that there is stigma to inhaler use, general dislike, followed by it is thinking that inhaler is habit forming. And one person in my study opined that inhaler is addictive, like cigarette and all. Then main inferences, we have to reinforce the practice of inhalers in primary care. We have to teach them, and we have to reassess it in frequent intervals, and we have to give more importance to those having frequent hospital admissions. And this, in this COVID times, we have to reinforce the inhaler practice so that we can reduce hospital admissions and other complications.
Good, Dr. Nishana. Topic again very relevant. My first question is, did you ask the patient whether they were given advice on how to use the inhaler? Was that question there?
Yes, that was in questionnaire, ma'am. I specifically asked who trained you to use inhaler, whether it is a doctor, nurse, or pharmacist, or you got information from other sources like medicines, TV. Nowadays we can see advertisement. There was one in Ayushman Khurrana showing.
Okay, so what was the reply to what was your
most of them, more than 80% of them relied only healthcare workers. Everyone was trained, but I think follow-up is not that much.
100% were trained, but only 39% still understood how to use it.
The deep inhalation part, inhaling the medicines, most of them are doing. Breathing out and breath holding, there are gaps. They know something, but they are not clear.
Okay. So why I'm asking you this question is the fault with the patient, or is the fault with the healthcare worker who is not explaining to them how to use it?
I think we have to follow up the patient. Initial, they are all trained. They are all trained at the OP itself, and they admit that. But later on, we have to follow up in each visit. How just ask them to show. And
so multiple reiterations probably are important. Every time they come to your OP, please ask them, bring your inhaler and show it to us how to use it.
Okay.
Or maybe when you train them, you ask them one demo then and there, let one puff go. It's okay. So you can just ask them to do it then and there in front of you, assess it and say whether it your right way of using it or not before you send them out of your OPD.
While we training the while we training the first time, definitely we will be showing, and then they will repeat it. Yes, on a repeated visit, they can first show us, then we can pick up the defect.
Very true, Dr. Roshi.
Okay, so maybe that is reflected over here. Like maybe you said that hospital admission patients, they showed better attitude towards this inhalers. Maybe they were being followed up, like they were given instructions repeatedly before their discharge as to the correct use of inhalers. Okay, so one outcome of the study is that follow-up is made. So what can you do to remove the stigma regarding the inhaler use? You said that many of them, they were having a stigma against this.
Stigmas, most of them had a general dislike to that device. Oh, this will be some.
So after the study, what can you do so that you can contribute towards removing the stigma?
We have to say the benefits. Then in current scenario, what I am doing is while taking duties and all, when patient comes for nebulization, they will ask. Then we will introduce inhaler, and it is very useful, and it is very handy. You can do it, and you can avoid coming into hospital. Then in these times, there is nothing
Okay,
much
maybe.
attractive that not coming to hospital.
Okay, maybe you can give them a short awareness program or a short health education regarding the use of educator. So maybe you can do something like that along with your OPD.
Okay, ma'am.
Okay.
Okay. Thank you, ma'am.
Probably telling them, what I try to do is tell them that, the side effects of the inhalers are much less than the side effect of the so-called tablets that they take.
Oh.
So you can explain like milligram versus microgram. You have an inhaler with a microgram, whereas you have a tablet with a milligram. So most people understand that concept. When you say milligram is like, 100, the 1,000th of your your microgram is 1,000th of your milligram. The amount of drug which goes in is much less. And it's so handy, like you said, it can be kept anywhere and taken with you, and it can many times prevent. So these are few points which you can probably, so like madam said, it's very important to probably take out that stigma before, unless the stigma goes, the patient is not going to take it up. So we should probably do an assessment and awareness and then redo this and see how
Okay.
much the stigma has changed. A post-compliance study later on would be a good idea. Thank you, Dr. Nishana.
Thank you, ma'am.
Thank you.
Thank you, Dr. Nishana. Can we go to the next talk by Dr. Prathamesh? Prathamesh Sawant. Are you here? Yes. Yes, just wait for the slide to come. You can check on your audio. Hello?
Am I audible?
Yeah, you're audible.
Yes.
Just a minute.
Prathamesh, registration number, please.
106, ma'am.
Prathamesh,
Yes.
you can start.
Yes. So good afternoon, everyone. First of all, I'm Prathamesh here. Okay. So the end product of whatever a clinician does through that practice reflects at the patient's outcomes. And our motto as healthcare professionals is to help patients and families take this shared decisions in enhancing their quality of life and minimizing the disease burden or illness that the patient or the family is suffering from. This holds very strong and is seen in family practice, as family physicians are the primary care providers. As we all know, access to healthcare is increasing across the country, but access to holistic and integrated multidisciplinary care teams is limited across the health systems. And this is very strongly seen in primary care, as well as even in tertiary care. It's more about addressing the current illness with an approach to minimize patient discomfort, but then it misses out on this longitudinal care plan that a family practitioner can provide. We believe as family practitioners that this approach of providing integrated multidisciplinary care plan to a patient can uh, help in providing first contact, comprehensive, contextual, and continuous coordinated care through collaborative learnings, capacity expansion, and getting to a cost-effective treatment plan or option to provide optimal care for the patient, with patient being at the center of whatever decisions that we take. This has truly proven to be of great value with the multidisciplinary approach that we initiated in our home-based primary care model back in 2019. I believe that there is a lot that we can do with this together in improving and strengthening health systems with this approach of multidisciplinary care, and enhance the quality of life of patients and families, as they are the end beneficiaries of what we do. So, taking an example of one of the case from our daily practice, we saw this patient as a team at his home, a 91-year-old male who came with complaints of hemoptysis, fever, and breathing discomfort. Also complained of mild lower back pain. He, on asking the history, they said that he had history of prostate cancer, for which he underwent chemotherapy. Patient had lots of hope to get not go further with it because he was not benefiting that well. So he had stopped the chemotherapy around 5 years back and had not repeated his PSA for a very long time now. With all these current symptoms that he had, they got a chest X-ray done at home, where they noticed a large white patch on the right apical region, which was extended towards the middle lobe. And on repeating his PSA, it showed to be 900 nanogram. So when we went home, we saw this patient, sat down with the family, examined the patient, found that there were no axillary lymph nodes or any other cervical lymph nodes present. Auscultation showed the reduced air entry to the right base and the right infrascapular region. Patient was febrile as well. So we sat down with the family, explained them the prognosis, and the family mostly wanted a conservative approach to improve his quality of life and merely not treat anything, because as they were not, uh, they knew that this was a metastasis and it was progressing as well from the other side. So we initiated the patient on antibiotics and took an opinion from one of our senior family physician who is our mentor as well, along with an opinion from an oncologist, to start this patient on Zoladex injection, 10.8 milligram, which is a GnRH analog. Along with that, we administered this injection at home. So as you know, this the needle with which this injection comes in is a 16 gauge needle, which is a very thick needle, and piercing this through the subcutaneous tissue of the patient in the abdomen was really painful for us, but the patient tolerated it very well. He did not even blink. So now the patient is fairly mobile, has no cough or fever. We had seen him 5 weeks before, and now he's comfortable, stable. We plan to revisit him at home in this coming week to repeat his PSA and chest X-ray. So when we approach the patient through this family physician's lens in a multidisciplinary team model, it provides a broader view of understanding the problem and helping strategize solutions towards it. As we all know, sometimes there might be an answer or there might be a right answer, but always we cannot say that we always end up in the right answer at the end of the day. But keeping the person in comfort can change lives. So we in our daily practice use these 5 principles that we apply for providing care to a patient, that is empathy, patient and family centered care, integrated team based approach, a holistic care plan, along with humility. So as you can see the triangle down there, it shows the 3 pillars of Aveksha, or the 3 cornerstones of Aveksha, wherein the apex is of practice component, where we use an integrated model. We have a physician who is a family physician, a palliative care specialist. We have Ayurvedic physicians, pull them in as and when required by the patients. We have clinical pharmacists, we have psychologists, we have physiotherapists, we have nurses, nurse practitioners, and we have nursing aid care providers. Along with that, the second component comes to the training, wherein we train healthcare professionals through internship and fellowship programs, as well as mentor some of the school students from class 9 to class 12 through a program called as Unheard, wherein they are more mentored towards the career development. And if they want to choose into family medicine, they want to choose into healthcare professionals, what they can accept. So all these things, along with the third component, is the research, wherein we use the concept of practice-based translational research, through which we accelerate these and leverage it through our collaborative networks and partnerships. So as a next step, we plan to extend this through scaling deep and scaling out using these practice values and reach multiple care providers across the country and globally to help them enhance their own care providing and their own practice to provide care and continuity of care to the patients through this. And as we all know, patients and families do benefit, are the end beneficiaries of what we do. So we plan to push this to the next level and scale it up that way. So it's been 2 years now that we started this home-based primary care in Bangalore city, and we have reached around 450 patients across the city, doing 1,200 visits in the last 2 years, with a retention rate of 96% across the board. So we see the entire spectrum of life from a newborn baby to a 102-year-old, 110-year-old patient. So thank you so much for giving me an opportunity to present our work here at this conference.
Judges?
Thank you, Dr. Prathamesh. It was a very good presentation. You said about the multidisciplinary team that is available. So are you doing these consultations via telemedicine, or are you consulting with all these multidisciplinary doctors through telemedicine, or are they coming in direct contact with the patient?
Okay. So as of now, when we began this thing, me and there is another colleague of mine, Dr. Ashujit, we started this as a team. So we started visiting homes. So visiting home is our primary thing. Teleconsultation is a follow-up thing, wherein if we are unable to visit their homes for a regular follow-up or during the regular things, we do telemedicine. We use telemedicine as a platform, but not most of the times. During COVID, we had to use telemedicine as a base platform because we did not want to carry any infection from any patient to any patient, because most of our clientele are elderly, and we did not want to risk the elderly patient. So we used to triage on the telecare and then go and see the patients. Also, the base thing that we provide to a patient is a doctor, clinical pharmacist, and psychologist team-based practice, wherein all these three visit the patient's home together across the city of Bangalore. And as and when need comes, we pull in an Ayurvedic physician, or we pull in a physiotherapist, or a dentist who can do home-based dentistry. Or also we have a huge connect with multiple hospitals across the city of Bangalore. So if any patient needs to be transferred or referred to a hospital, we refer it accordingly and then follow up at the hospital as well, so that the patient has that continuity of care even at the hospital and post hospitalization also. So we pull in people as and when needed, but a physician, a clinical pharmacist, and a psychologist are the base who go into the patient's homes.
Okay.
Dr. Prathamesh, very nice presentation. I think the concept of home-based care in family physicians is still picking up. A lot are still, having a OPD-based care only, and you've set a good example. My one suggestion will be to not use the name of your center and preferably put it as a home-based care, because that just add values to the way you're trying to tell it. I just want to know, do you also use the other basic principles of palliative care and all for this patient?
Yes, absolutely.
Because
exactly. So it's as palliative care, most of them think it's more of terminally ill or end of life care, but it actually starts from the diagnosis to the treatment to the entire end of the patient's care plan, wherein the basic concept is to provide emotional, psychological, and physical symptomatic relief kind of a care to the patient, wherein the patient's quality of life is enhanced. Even if we do not have the right answer to treat their underlying cause or underlying condition, we have to keep the patient comfortable, because that's the dignity with which the patient lives. And post the patient, after the patient dies as well, that is the dignity that the family also carries along with them. because these are the moments which family do remember at the end. So
I would also add financial, although it is not there in the actual basic principles, but I would say in India, at least financial
absolutely.
will also come as one of your priorities when
Yeah.
you treat a
So
patient.
exactly. So now with this training programs, we have been reaching out to nurses across the country. We currently have a program running in at Indore where we are training nurses to be nurse practitioners or family practitioners. And it's more towards patients who are unable to afford the healthcare or afford accessibility to quality healthcare in Indore with two slums consisting of 42 minor slums in them. So we have been reaching out to almost 2,000 patients with that. And along with that, during the COVID, we took care of nearly 1,200 patients on telecare, providing them at least a contact of reach to access healthcare, especially in the lower socioeconomic background across the city of Bangalore, as well as a few cities across the country. We are taking care of 13 nurses.
Yeah. One more question is, are we trying to integrate the Ayush method? Because is there going to be a conflict of treatment there? Because their concept is different, our concept is different. So you're starting off with the concept from modern medicine and then trying, and how well are you integrating it and how acceptable it is among the patients?
So, as a continuation of what Dr. Swapna asked, will it be a patient's choice whether they choose any other system of medicine, or will you be deciding?
No, we keep it open to the patient because many of the patients, as you know, they would be taking some or the other Ayurvedic medications, especially when it comes to end of life or palliative component to it, where the patient might be suffering from something that we might not be having and hold on to, like Alzheimer's, dementia, wherein allopathic medicine might not help so much for a patient, but to keep the patient calm, to keep the patient's quality of life improving, we use the allopathic component. But to take care of certain things wherein the patient is bed bound, like managing the large bed sores and things like that, we use certain Ayurvedic practitioners who help us. And there are certain Ayurvedic oils which are available that we use in our daily practice to take care of larger wounds and stuff. And it has given us very good, what do we say, a very good outcome to the patient. Wherein we have seen certain bed sores where the entire 6-inch
Can we go to the next?
You did little bit overshoot a bit on your time slot.
Oh, yeah. I'm so sorry.
Okay, thank you, judges. We'll go to the next talk by Dr. Rifat. Rifat, are you there? Yeah. Kindly stick on to time, 3 minutes. Okay.
Rifat's registration number, please.
Registration number, Rifat?
Yeah.
Good afternoon, ma'am. My registration number is, serial number is 17.
17, okay.
Can I start?
Yes.
Yes, you can start.
Good afternoon, everyone. I'm Dr. Rifat Noorjahan, DNB resident in Family Medicine, Sagar Hospitals, Bangalore. Today I'm going to do a poster presentation based on my study, which is a study on the influence of maternal anthropometry and hemoglobin on the neonatal anthropometry, which was conducted in a tertiary care hospital in a metropolitan city in South India, under the guidance of Dr. Shantala S., Senior Consultant in Obstetrics and Gynecology, and Dr. Umakanta Adiga, Senior Consultant in Pediatrics. And starting with my study, the anthropometric measurements, they are an important clinical tool for the early diagnosis of low birth weight in newborns. And this maternal anthropometry, it is having a very profound influence on the neonatal anthropometric measurements. So early assessment of the mother, it always provides a framework to anticipate the low birth weight in newborns, and it serves as a starting point for appropriate interventions during early pregnancy. The aims and objectives of my study were to assess the correlation between maternal anthropometry and newborn anthropometric measurements, and also to assess the correlation between maternal hemoglobin and neonatal birth weight. And my study design is a prospective longitudinal observational study, a cohort study with a study duration of 18 months. And the inclusion criteria included all pregnant women who come for their first antenatal visit before 13 weeks, and all who have attended at least 3 antenatal clinic visits, and all pregnant females in the age group of 18 to 35 years, and neonates delivered at 37 to 40 weeks of gestation, either vaginally or by a C-section. And exclusion criteria included pregnant females with other comorbidities like type 2 diabetes mellitus, cardiovascular diseases, multiple pregnancies, and mothers with placenta previa as well as abruptio placenta, and pregnant females with pre-existing hypertension, and also preterm babies and postterm babies were excluded from my study. And the sample size of my study came up to 162. Out of that, we lost 12 cases for follow-up, and 150 samples were submitted for the analysis. And the conclusion of my study was that based on the maternal anthropometry and the maternal hemoglobin was the most important factor which had a significant impact on the neonatal anthropometry, that is mainly on the neonatal birth weight. There was a strong correlation between the maternal hemoglobin and the neonatal birth weight, which indicated the impact of nutritional status of the pregnant woman. And there was a positive correlation. The maternal height, it did not have any impact on the neonatal anthropometry. And coming to the limitations of my study, since this study was conducted in a corporate hospital in a metropolitan city, there were relatively affordable sections of pregnant women will come for accessing the treatment. So the generalization of the study had to be applied in a limited context to similar demographic population. And also the serum micronutrient profile was not considered while taking the pregnant woman's assessment. So it could have a compound effect. A compound effect of such micronutrients will be there on the newborn anthropometry. That can't be ruled out. So that is also a limitation of my study. And another thing is paternal anthropometry was also not included, which can also have an impact on the newborn anthropometry. And the recommendations from my study are it's already there. Maternal anthropometric assessment, it should be part of all antenatal care programs beginning from the first trimester visit. It has been carried out in all urban areas, but in rural areas still they lack in carrying out proper antenatal care visits. So being a family physician, I want to highlight the importance of antenatal care to pregnant women, and counseling the mothers, antenatal mothers, regarding the importance of intake during pregnancy, and also counseling them regarding the impact of anemia on the birth weight of the newborn. And also based on my study, I recommend a model based on the maternal nutritional status, then the maternal and paternal anthropometry, which can predict the various anthropometric characteristics of newborn. And the take-home message is like in a my take-home messages in a resource-constrained country like India. Something like maternal anthropometry, it is a easily measurable and also an inexpensive parameter which will help in easy identification as well as early identification of high-risk pregnancies, and thereby preventing the incidence of maternal as well as neonatal morbidity as well as the mortality. And also measuring the maternal hemoglobin, that also it's a very inexpensive test which will help the healthcare personnel to early pick up those cases of anemia and manage them accordingly. Thank you.
Judges, please.
Thank you, Dr. for being on time there. I think it was a quick presentation. What were the anthropometric measurements that you took in the mother, and what did you take in the fetus? I mean, the infant.
Mothers and maternal anthropometry, I had included the maternal weight and the maternal height, and based on that, the maternal BMI was calculated. But more than the maternal BMI, the maternal weight and the weight gain had a positive correlation with the neonatal anthropometry. And the neonatal anthropometric parameters that were taken were the neonatal birth weight, then the length as well as the head circumference. And the maternal anthropometric parameters as well as hemoglobin, they didn't have any correlation with the newborn length as well as the head circumference.
Okay. And how often did you do it during the pregnancy?
Pregnancy, minimum of 3 antenatal visits I was taking into consideration. Like during their first visit, when they came as soon as the pregnancy was confirmed, and then the second values were considered at 28 weeks of gestation, and the third one at term.
So did you find any difference in people who actually had an improvement in hemoglobin? So suppose you had seen in the first visit with low hemoglobin, and then if you were able to treat the hemoglobin properly, did you find it to be a positive correlating factor?
Yes, ma'am. Early detection of anemia, with a hemoglobin of less than 11 gram per deciliters, we were able to properly intervene during early pregnancy and had found that there was an improvement in the hemoglobin towards the end of pregnancy, except in few cases where other confounding associated factors like thalassemia trait, all those things we were not able to correct. But other than that, nutritional iron deficiencies we could correct, and that had a good outcome in the pregnancy too.
I think that arm you should project them, because that gives a very positive outlook as to how early treatment will improve the neonatal outcome. Roshni.
Okay, and you were saying that you were taking weight as an anthropometric parameter. Okay, so how did you correlate it? Like the gain in weight during pregnancy, like how did you do the correlation with the fetal?
Normally we are expecting a weight gain of 9 to 11 kilograms. It's considered as a normal weight, but since it was a corporate hospital and that too in a metropolitan city, normally we found majority of the women coming under that normal weight gain which is required. And what I used to do was like for every visit I used to record their weight, like all 3 visits we used to record their weight, and a weight gain of 2 kilogram in every trimester, it was considered as normal. So if there was a weight gain of less than 2 kilogram, I used to go back to that patient and then assess the history and also the examination, and a short history based on their nutritional status, including the proper intake of iron supplements, were all taken into consideration. And if any intervention was required during that time, that was also incorporated in my study.
So to add to it, did you also take obesity into consideration?
Yes, ma'am. Based on the BMI, I made a classification based on the WHO classification of obesity, and obesity that was also taken into study, and the overweight as well as obese women, in them even fetal macrosomia was found in the study.
So a patient who was obese right from the beginning, so did you exclude them from the study?
No, ma'am. Only if they have some other predisposing underlying abnormalities like any systemic disorders or any pre-existing diabetes or GDM, I had excluded them from study. But other than that, based on weight, there was no exclusion criteria.
Okay.
Paper could have been more valuable if you had added these 2-3 points, which even the other spectrum of nourishment, not just the lower spectrum, the higher spectrum also, and how it can affect the outcome.
Yes,
and also if you can do it in a community place, in a community setup than a tertiary hospital, especially a place where you yourself told is a limitation.
Yes,
you can do it in the community, it will be, or maybe a comparative study between a community and a tertiary hospital, if you have a primary healthcare center or something attached to it.
Yes, ma'am.
Thank you, judges. Rafat, thank you. Yeah, next is Samina. Samina, are you available?
Yes, ma'am.
Yeah. I think Arati, the next slide.
Should we note down the registration, or is it enough just noting the names, Dr.
Yeah, names will be okay.
Names should be fine.
Names will be okay. Samina, you can start now.
Good afternoon, ma'am. I am Dr. Samina, first year family medicine resident in Loth Hospital, Kochi. My poster is about hyponatremia, who is the real culprit. Nowadays, most of the patients are under the treatment of more than one specialist doctors. So as a family physician, we should always check for the possibility of complications of this polypharmacy in especially in elderly patients. Here is 70-year-old female presented to the emergency medicine department of our peripheral center with generalized tiredness and memory impairment for last 3 days. No history of fever, vomiting, weakness, or headache. In her past history, she was having bipolar disorder for last 4 years and systemic hypertension for last 2 years. The relevant drug history, she was on tablet sodium valproate 300 milligram for last 4 years and tab atenolol for 50 mg for last 2 years. On physical examination, she was conscious oriented and blood pressure was 160 per 100 millimeter mercury. Pulse rate was 80 per minute and all systems were within normal limits. Investigation. Her hemoglobin was 12 gram per deciliter and serum sodium was 115 milliequivalent per liter, which is low, and serum potassium was 2.7 milliequivalent per liter, and TSH levels were normal. Cortisol levels also normal, and serum osmolarity was 66 milliosmol per kg, which was low, and urine osmolarity was 369 milliosmol per kg, which was high. So we are assessed her serum valproic acid level, which is also normal, and our diagnosis was syndrome of inappropriate ADH secretion, probably drug induced. The reason was sodium valproate, and she was managed with 3% normal saline infusion and injection KCl infusion, and the serum electrolytes were monitored regularly, and the psychiatric consultation was done, and drug dosage was also adjusted. She was not on regular follow-up on psychiatric department, which was the reason for this CR. And she was on regular follow-up in our family medicine department, and she was discharged after 3 days with normal serum sodium levels, and she visited our clinic after 2 weeks and she was normal and there was no signs of hyponatremia now, and her sodium level were also 135 milliequivalent per liter. And so the role of family physician is in when we get a case, we should check for all possibilities in elderly to avoid the complications of polypharmacy. That's it. Thank you.
First of all, congrats being a first-year resident. You have presented in such a good platform, and I really appreciate that you've done that. You did stick on to the time. Also, please keep it up. Find out more opportunities whenever you get, and do present. Okay. So, actually, where did the question of polypharmacy come here in this patient was the first thing in my mind.
She was hypertension. She was under treatment of a physician. And she was also on psychiatric medications.
But polypharmacy, usually we need at least few more drugs to come into the picture when you say polypharmacy. Okay. So probably here, definitely it was any of these psychiatric medications, many of, even steroids, diuretics, all of them are known to cause hyponatremia. So always drug-induced hyponatremia should be kept in mind, which is very, very true. So maybe that particular word I feel was not the right thing to use here, since there is no polypharmacy until unless somebody has given something else which you have forgotten to add here. And also this probably like shows the value of a family physician to think about all possible causes when a patient comes to you with memory impairment. So probably a 70-year-old patient with memory impairment. One more thing is you didn't tell us how many days was the memory impairment. You just told 70-year-old female came with generalized tiredness and memory impairment. So I initially took it as Alzheimer's or something like that. So it was important to tell us that it was probably an acute memory impairment. That is what I hope you wanted to convey. Correct? Yes. Am I right? Yeah. So a little bit of more history to make us understand the importance of doing a sodium. Otherwise, I wouldn't even think of doing a sodium if the patient is a Alzheimer's patient or somebody who's having a multi-infarct dementia. Okay, so those are just my comments, but congrats really to do it as a first year student. And I think management wise, probably your seniors would have done a very good job, including. So, yeah, Dr. Roshni, sorry, I will take it.
Dr. Samina, did you consider any other possibilities for this memory impairment and disorientation over here? Did you consider all the DDs?
Yes, ma'am.
Differential diagnosis?
Alzheimer's disease, in this case, it is an acute memory impairment.
Or as a family physician, did you know that she had similar episodes before or something like that? So that you could directly come to this conclusion? No.
No history of similar episodes in the past.
Okay. So she has been coming to show in your clinic before also. So you had an idea that she was taking treatment from the psychiatric department?
Yeah, she was started on on sodium valproate in 2016 actually. The records were available for me. And she was not on regular follow-up after that. And she presented in our emergency department in the late night actually with generalized tiredness and memory impairment.
Okay.
So potassium was also low in this patient.
Yes.
So, yeah, so your differentials with both being low and your differentials with if sodium is low and potassium is high is little different. So that's what madam was also asking, probably apart from memory. There are so many causes of memory impairment. So a little bit more on what was there actually when the patient deficits. Was there any neurodeficits when the patient presented?
CNS examination, there was no focal neurological deficit or any other positive points in systemic examinations also.
So maybe you can elaborate a little bit more and tell us so next time, maybe you can tell us how you came to the conclusion that this is the underlying cause. Okay.
Okay.
Thank you, Dr. Samina.
So thank you,
Can we
Dr.
go to the
Samina.
next talk? Next talk by Dr. Subin Babu. Are you there?
Yes, madam. Am I audible?
Yes. Arati, next slide. Yes. Subin, you can start now.
Okay, ma'am. Good afternoon, judges and my dear colleagues. I'm Dr. Subin Babu, Junior Resident in Family Medicine from Calicut Medical College. I'm here to present the case on an atypical presentation of infective endocarditis. So a short introduction on infective endocarditis. We all know infective endocarditis is a common life-threatening infection and it can have variable clinical presentation. Hence, therefore, being aware of atypical presentation of infective endocarditis is very important for early diagnosis and prompt treatment of this life-threatening disorder. So I am here to present a case report of a 46-year-old multiparous female. She was a manual laborer, a divorcee with history of poorly controlled type 2 diabetes mellitus for past 10 years and hypothyroidism for the past 4 years and recently detected hypertension. She now presented with high-grade intermittent fever associated with chills and rigors for 3 days, after which the fever subsided, but she developed sudden onset puffiness of face, pedal edema, breathlessness, and orthopnea. There was associated dry cough, nausea, and vomiting. There is no history of any addiction, surgical procedures, any IV drug abuse, rheumatic heart disease in the past. There is no urinary complaints. And socioeconomic history, she belongs to a very poor socioeconomic class and she finds it difficult to have a balanced meal at least once a day. And on examination, the patient is moderately built and nourished with a BMI of 24. There is pallor, there is puffiness of face, bilateral pitting pedal edema, there was angular cheilitis, glossitis, there was cheilitis, glossitis, and angular stomatitis. Skin was dry and lusterless. Her BP was 156 over 90 millimeters of mercury. Her pulse rate was 100 per minute. She was tachypneic, and there was a grade 3 pansystolic murmur, which was best heard in the apex radiating to the axilla. There were fine crepitation in the bilateral axillary and infrascapular area. All other system examinations was within normal limit. And on investigation, she had a hemoglobin of 8.7 grams per deciliter. Her total count was 17,600 with neutrophils 85% and lymphocytes 10%. Her ESR was 100. Serum electrolytes sodium was 143, potassium 3. There was albumin, globulin reversal. Her blood sugars were uncontrolled. FBS was 420 and PPBS was 390. Her thyroid function test, her TSH was 125. Her RFT, urea was 62 and creatinine was 2.3. And urine examination showed numerous pustules, but there was no RBC crystals. And since we found an pansystolic murmur in the mitral area, we did an echo, and there we were able to find a possible infective endocarditis with moderate MR with caudal rupture and failed anterior mitral leaflet. And her blood culture and sensitivity showed resistance to penicillin and cotrimoxazole, and it was sensitive to gentamicin, vancomycin, and ceftriaxone. USG showed moderate fatty liver changes. All others was within normal limit. And hence a diagnosis of infective endocarditis with severe MR was made, acute kidney injury with pulmonary edema and features of uremia. Along with it, she had uncontrolled type 2 diabetes mellitus, urinary tract infection, hypothyroidism, hypertension, non-alcoholic fatty liver disease, anemia with multiple nutritional deficiency. And she was managed with injection ceftriaxone and gentamicin for a period of 6 weeks. She was given injection furosemide to reduce the pulmonary edema. She was given her blood sugars were managed with insulin. She was given thyroxine, iron, folic acid, and vitamin supplements. And also she was advised regarding the importance of a balanced diet. And take-home message was here when she initially presented, we thought her diagnosis was pyelonephritis with acute kidney injury. But on finding the murmur, we were prompted to do an echo, and as a result, we could find her diagnosis and treat her early. And also, the next take-home message is the need of creating the awareness of balanced diet, and also, if possible, to help in enabling schemes so that even people below poverty line can afford a balanced diet. Even though she was not able to take balanced diet, she used to take more of carbohydrates, and hence she had all other disorders, which like non-alcoholic fatty liver disease and diabetes, which are dietary and lifestyle disorders. So we have to create awareness among our people regarding the necessity of taking a balanced diet. Thank you.
Judges, please.
Thank you, Dr. Subin, for that nice presentation. So, can you tell me something about the background of the study? Like, can you tell me something about similar atypical presentations of infective endocarditis?
Ma'am, the other atypical presentation can be, they can manifest as embolism, like systemic embolism. It can be an embolism to the brain, or it can be an embolism to the renal artery or peripheral artery embolism. It can be a splenic infarction. So they can present in varied ways, ma'am, as a result of embolism.
Okay, so it was a murmur that you detected that prompted you to think about this infective endocarditis over here.
Yes, ma'am.
Okay.
How many blood cultures did you do for this patient?
Ma'am, for this patient, 2 blood cultures was taken.
Ideally?
Ideally, it should be 3 or more, ma'am.
Okay, so did all of them show the same organism with the same sensitivity?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So, what do you think could be the reason for this resistance to penicillin and clotrimoxazole? Was it an MRSA?
It was Staph aureus, madam, but might be an MRSA.
Okay. I was actually a little surprised because a pansystolic, what made you think that it could be not just a flow murmur versus an organic murmur here?
Ma'am, since she was not improving that much with our initial management, like AKA, we were treating it as pyelonephritis with acute kidney injury. but she was not improving that much. So, and since we found a murmur, there was no history of any previous cardiac disease or ischemic heart disease or rheumatic heart disease. So we did an echo, madam.
Yeah, so probably to tell you that it's not a flow murmur. Of course, she's anemic, so you can expect a flow murmur there. I would say
Yes.
a pansystolic murmur is little unlikely to be a flow murmur. So I
Oh,
would
okay.
have thought in that
Okay.
way that you have a
Okay.
pansystolic murmur, so which is very unlikely to be, you know, a
Okay.
flow murmur.
Flow
Otherwise, in
murmur.
this
Okay.
kind of you are presenting a patient who's from very low socioeconomic background,
Yes,
a
ma'am.
widower who doesn't have much financial. So possibility is that it could be one of those, the long-standing anemia leading to a flow murmur.
Okay.
So that way, even I wouldn't think of an endocarditis as the first, you know, presentation when somebody like this comes from a low, so you know, one of those common other infections. But
Yes, ma'am.
good thing that, you know, we could get a diagnosis which is like that. So treatment wise, how long did you treat her?
Madam, in the hospital, she was given treatment for 2 weeks, and then she was discharged to a local hospital for IV antibiotic medication, madam, for a period of total 6 weeks.
So that's very important that we also reiterate that the patient gets long-term treatment on infective endocarditis. But good case brought up. Probably a few things which didn't fit into was like, you know, why you thought of. So possibly it is the pansystolic is what I feel from this. Otherwise, I wouldn't think of. Okay, thank you.
Thank you.
Thank you, Dr. Subin. We'll go for the next talk. Kolis Ansari. Dr. Kolis Anwari. Okay. Are you there?
Yes, I'm there.
Yeah, you're audible. We'll
Am
wait
I
for
audible?
the. Yeah,
Sure.
you're audible. You're audible. We'll wait for the image. Okay, you can start.
Sure, sure. Respected judges, and thank you for giving me the opportunity to present. So the topic today is home-based primary care of musculoskeletal problems related to pain and disability, an illustration of a patient and family-centric interprofessional model. A very common problem in our home-based primary care for the geriatric age group is pain, which can lead to decreased quality of life, increased fall, reduced functional independence, balance dysfunction, disability, and many other problems as well. So our entire aim of this paper was three things. One, to help us identify the burden and disability caused because of the pain, and integrated care planning for assessing and improving the patient's quality of life by the interdisciplinary team, and the main focus is to keep the patient and family at the center of the integrated care approach. The integrated care approach or the interprofessional collaboration is not something which is relegational, but rather a closed knit interprofessional collaboration between the interdisciplinary team. And some of the important things what we understood through the entire collaboration was the utilization of an integrated and undifferentiated yet holistic approach to understanding a patient's context and interplay of family dynamics, which played a very important role, as well as the social relationships and cultural background, and the economics of the causation and presentation of the illness and the responsive treatment. A lot of times we understood that the patient at a scenario of the home is able to go for a long-term treatment and a long-term recovery based on how the family too supports the patient in different aspects. The other important thing is we build on the existing trust between the doctor and the patient relationship. A lot of time the family physician and the clinical pharmacist and psychologist visits at first, and then they give me the reference. And during that, the relationship is already been built, which helps us to take it to a much more higher level of the treatment itself. And another important thing what we realize is the professional boundary is not very rigid, but it's very fluid and not well defined. Because a lot of times the physicians and the pharmacists and the psychologists who visit, they do everything. But at the same time, when there's any issue comes up or when anything comes up, because as a physiotherapist, I have to go and visit them every day. So if there's any issue which comes up, I can immediately call the family physician and just tell them what's happening, and she helps me to take it forward from there. So it's not well defined. It's a more intercollaborative approach. And another important thing, what we understood is labeling and formal diagnoses are deemed less important in the conscious understanding of giving greater importance. And then another important thing is the shared decision making and preservation of autonomy is the heart of the approach. Patient autonomy is what we have seen is the most important aspect in our approach. And often using a team-based approach, drawing on the experience of other family physicians, organ system like specialists and other specialists was the most important aspect in what we learned what we learned during the treatment. And if anyone see the chart over there, which speaks about how as a team, what are the different components we looked at. And keeping the patient at the center, and then we had a multidisciplinary team as well as a comprehensive and an integrative approach, the different dynamics of what we had used. Yes, ma'am.
Judges, please.
Thank you, Dr. Anwari. I think you have mentioned here that there are 3 unique cases, but I didn't get to see about the cases. What were the 3 unique things that you were trying to tell us?
Sure. So the 3 cases were, ma'am, one of the cases was about a 66 years old.
Yeah, make it very, very, very short. Just,
Sure.
what was it and what it made, just very
Okay.
one sentence probably.
So the first case was a 66 years old patient who had a lot of issues with the eyes and uncontrolled diabetics and blood pressure. And she even had other disabilities because of pain, which was not correctly diagnosed about 10 years ago. So with our approach, we are able to help improve quality of life and reduce the fall as well as control the diabetics and hypertension through regular monitoring of the medicines. And the second case was about a 91 years old patient who had a lumbar compression fracture. And we treated her conservatively at home for about 6 to 8 weeks. And now she's able to live a happy life with a pain-free life. And the third case was a 66 years old patient who had a PTCA 15 years ago, and she had a complete heart block about in February this year, last year February, and after the surgery she wasn't able to stand and walk for a long time. But then with a team-grade approach of controlling all the other vital parameters and the physiotherapy approach, we are able to help her improve quality life as well as walk, as well as make her function independent.
So all of them had a very positive outcome because
Yes,
of the
ma'am.
collaboration. That is what you were trying to tell us.
Yes, ma'am.
And where would you put a physiotherapist's role? Right from the beginning, or at what point will you? Because I guess you're the physiotherapist there. At what point will you tell that the physiotherapist has to come in? Is it in the very acute phase itself, or
Ma'am, one important aspect what I have understood is it's in between. There's no exactly defined phase. Like for us, the benefit is we used to every evening or at least once in 3 days have a team meeting. So that is the place where we used to come together and understand that this is the place where I fit in, or as a physiotherapist, I fit in. So I would say that boundary is not really predefined. It's all depending on how the patient's progresses. Like if you see, for example, the second patient of 66 years old patient who had a PTCA and who had a complete heart block in February last year had come in the very third week itself. But for the other patient who was 91 years old, I came after the entire phase is over of acute.
So it will be a teamwork. That is what you are
Yes,
saying.
ma'am.
Okay.
Yes, ma'am.
So who will be taking the role of the team leader?
Ma'am, here is generally the family physician who takes the lead over here, and from there we take it as a team. So the family physician basically goes for the first visit, along with the clinical pharmacist and the psychologist, and then we take it forward from them.
Okay.
Judges, okay, can we go to the next talk?
Thank you, Dr.
Thank you, Dr.
Yes,
Paulis.
thank you.
Next talk, the last talk will be from Dr. Radhika. Radhika, are you there?
Yes, I'm here.
Yeah, just wait for the image. Come.
Sure.
Okay, Radhika, can you see it? Yeah.
Yes, I can see
You
it.
can
Thank
start
you.
now. You can start.
Great. Thank you. Good afternoon, everyone. Good afternoon, judges. Firstly, at the offset, I'd like to clarify I am not a doctor. I'm Radhika. I'm a social entrepreneur, and I'm the sexual and reproductive health lead at Swasti Health Catalyst. I've done this in collaboration with PCMH, so it's really a privilege for me to be able to present here today. I'm going to be talking about how the menstrual cup, which is a really old technological innovation, can be used to manage in menstrual health and well-being in a new way, as we discovered. So basically, the menstrual cup is a very old innovation. It was first made in 1937, and it was really, really significant at this point to the way women manage their menstruation, and I'll come to that in a bit. Through this poster, I'd like to demonstrate how menstrual cups can be used in dealing with complicated menstrual disorders. I'd like to elucidate the lifestyle and planetary health benefits of using cups, as well as establish this intersection between social entrepreneurship and traditional clinical practice. So the case that we dealt with PCMH was a case where a lady came in with, she was diagnosed with deep vein thrombosis. And following that, there was an understanding based on her history that she had long-standing menorrhagia as well as a low hemoglobin count. The doctors went ahead and intervened clinically through provision of blood thinners. There were some considerations against the use of injections based on her lifestyle and financial capability, etc. And following that was when I came in as a social entrepreneur through a non-clinical intervention, because when she finally started bleeding, she was bleeding very heavily, so much so that every 10 minutes she had to change her absorbent. Now, this was very concerning, especially with her low hemoglobin levels, as well as the fact that she was on a blood thinner. So the reason why we went ahead with suggesting a menstrual cup as a possible intervention was primarily driven by the STEPS decision-making framework: safety, tolerability, efficacy, price, and simplicity. So on the right-hand side, you see a graph that compares menstrual cups as well as sanitary napkins. Menstrual cups are definitely safe, maybe even more safe than sanitary napkins based on their usage. They're very tolerable to the body. They're very, very comfortable. They're extremely efficient in terms of collection of blood. They're a great price point, but the only downside is the simplicity. We argue to include a fifth sort of decision-making framework, which would be planetary health. A single woman, when she's menstruating, utilizes about 3,600 sanitary napkins in her lifetime. Now, you as doctors and me as a social entrepreneur know the planetary impact of this. These sanitary napkins never degrade. Therefore, there is a huge case to be made for menstrual cups, especially in dealing with conditions like this, because they can go a very long way in improving the quality of life of a patient. A study was conducted where they sort of went to different women who were experiencing menorrhagia, and the most common word that came up was miserable. We bleed for 5.75 years of our lives. It's a huge part of our lives. It's similar to bleeding. There's no reason why we should feel miserable through that period. The patient who came in as well was suffering. She had low quality of life at that point. She was not sleeping. She was not being able to stand, sit, walk around. And when she started using the cup, she actually slept that night, and she was able to stand up and walk around and perform her daily functions. It allowed her to go 3 or 4 hours without visiting the bathroom to change her product. So there are lots of causes of why we should consider this. I realize I'm over time, and I'll hand it over.
Very nice point put out, Ms. Radhika. And just a suggestion, your poster was a little too overcrowded that, I'm
Fair.
a little maybe without a specs, I'm able to little bit not clearly read it. A lot of good points that you brought up. If I remember, the age of the patient was 40?
The age of the patient was 44.
44. Okay. So at this point, did you even consider that, she can be using some other methods, like, because she's going to bleed for another just few years maybe. So something like a progesterone intrauterine device, something like that. Maybe you're not a doctor. So
Yes.
was this decision taken in collaboration with a doctor's, a gynecologist's advice?
Sure. I can't answer to that because I was brought in at the point of management. And that's actually where this intersection with social entrepreneurship and clinical practice comes in, where as social entrepreneurs, we can leverage the clinical practice of a doctor to actually benefit our customers, and customers of the doctor can benefit from social enterprises such as us. So we were brought in at the stage of management. So I'm sorry, I can't answer to
So
that
the decision
point.
was already made.
Yes.
So you were
Yes.
just brought into, okay.
Yes.
The other thing is the financial burden of the menstrual cup versus the pads for a person from a poor socioeconomic status. So which do you think, scores there?
Definitely the menstrual cup. The menstrual cup, especially the one that we have, it costs 400 rupees. At 400 rupees price point, a woman is making her investment back in about 2 months, and especially if she is menstruating with changing a product every 10 minutes, that's probably a 1 month return for her.
Right. As far as I knew, I thought it was a little more expensive.
Right. The price point has come down at this point, which is why there is a huge case for it.
Great. That sounds good.
Yeah.
Dr. Roshni?
Okay, as Dr. Swapna mentioned, the posters, it could have been formatted a little bit more. Okay.
Thank you for the feedback.
And a good concept also, being more eco-friendly also. That is what you mentioned. Okay.
Yeah.
Rather than, as well as the benefits for the patient. Okay. So that's it.
Thank you, Dr. Radhika.
Thank you.
Sorry. Thank you, judges, Dr. Swapna and Dr. Roshni, and all the participants. I request Dr. Swapna and Dr. Roshni to tabulate the marks, the judges evaluation form, and send it to me only. Please send it to me by 2 o'clock.
Sure, sure.
Okay.
Do we have a preset form, Dr. Indu? So that
Yeah, that's a judges evaluation form. It was sent, I think.
Okay. In my mail, is it? Yeah, I will just
Yeah.
go through that, fill it up because I've made my points here.
I think you were not receiving the mail. I think there was some problem with the mail.
Yeah, let me just.
And I sent it everything through WhatsApp also.
Oh, is
The
it?
judges evaluation form. There are, I think, there are about some few points which you'll have to fill it up. Total of 100 marks.
Okay.
Total of 100 marks.
Yeah, I will just go.
I think Dr. Roshni is
I
having
don't
it.
think I have got your.
Have you got my WhatsApp? I think I have sent it again in your WhatsApp.
Just cross check.
Ma'am, can I stop the live streaming?
Yeah.